people coming? Do we still need to wait?
It's okay, doctor. We can just start.
Okay.
By the way, doctor, will it be okay if doctor record this session?
Yeah, I'm going to
Okay.
turn on the recorder.
Okay, great. Thank you, doctor.
Okay, great. So let's go to the first one. Dwayne, just now you were about to highlight about this case, so please go ahead.
All right. Good afternoon, everyone. So I'm going to explain about the pre-op condition that may impact the anesthesia. So what I can summarize from this assignment for pre-op condition, the most important thing that we want to do is to make sure that the patient we want to control their heart rate. We don't want their heart rate to be too low or be too high. So that's one of the most important factor that we want to take into consideration. And then the drug distribution. So about the drug distribution, it's very straightforward. We can just read from the points here. So that's the only two things that I can summarize from the pre-op condition. And as the one that is highlighted in yellow about sedative in depressed patient, it's very it's just to make sure that the patient won't their heart rate won't fall too low, and the patient will have a higher chance of dying. And then that's about it for the pre-operation condition. So about the second one, the pre-operational stabilization, though I will only explain the highlighted one. The rest we can just read on our own if that's fine. Okay, so this one, the baseline blood tests include blood count, chemistries to assess organ function, and electrolyte, mineral, and acid-base status. So after discussing with my group mates, minerals and electrolytes are actually the same thing, doctor?
Sorry, mineral is the same as electrolytes?
Yes.
Oh, okay. So that means actually like these words is not necessary to be there.
Yes. It's all.
Okay, so
it's the same.
Yeah, I was wondering what you mean by minerals. So you actually like meaning to talk about electrolytes.
Yes.
Oh, okay. So a quick response to that. So when we talk about electrolytes, that probably will impact on anesthesia. The main one, it would be your sodium, potassium, chloride. So this would be the three main electrolytes. There probably are others that's also important, like calcium, also may impact, have some effect on the anesthesia. Okay. But the major one that can affect on the electrical conduction and maybe can predispose the heart to arrhythmias. So you need to remember it would be the potassium, which is usually is talking about hyperkalemia. All right. And the other one is calcium. All right. So calcium can also actually like affect, although some others that probably less well kind of like emphasize, but there are some comments is actually related to the magnesium. So, but then you must know at least, like potassium and how it can affect. But relevant to pyrethrum, usually it is, like potassium, we usually, like it's not kind of like well known that it will be really high or really low unless it have other concurrent problems with it. But if let's say the animal is severely dehydrated and also have severe metabolic acidosis, they may have some degree of hyperkalemia, okay, high in the potassium. That's to actually like take note lah. Okay, so basically, if you talk about pyrethrum, first thing is to know that it is accumulation of pus in the uterus. So, and then as your friend have written here, usually, so there are two types, whether it's closed or open. And usually is the closed pyrethrum usually are the one that are presented to be, their condition will relatively more sick. Okay, but not to say that the open pyrethrum, they will not be sick. They will be actually presented sick as well. Depends on how chronic it has been, how much of like pus has been accumulated for how long. So the longer the condition has persist, so the longer it has been exposed to the toxins, especially if they have E. coli and the E. coli have been producing toxins and be absorbed into the circulation. So these toxins are actually like causing problem to the kidney and to other organs. So the animal, if actually like has been exposed to a lot more of the toxin at that time of presentation, they will appear more sick. They will look be shocky. They are in toxemic condition. And if like this pyrethrum have rupture, it also may have not only in toxemia, so it start to be septic as well, and there's also like the organism into the circulation, so the animal is in septicemia. So that's why so when you have pyrethrum, of course you need to actually like look for these conditions. So if the animal is actually like not sick, so like whatever you want to actually like use, probably not going to make a big deals. But somehow they would have actually like be exposed to actually like this toxin, and you need to evaluate on the type of like derangement in terms of dehydration, fluid changes, electrolytes, acid-base balance, those things. Other than that, if let's say, like they are already in septicemia, obviously your risk become higher. So you want to try to stabilize that before you actually like put the animal under anesthesia to perform removal of the pyrethrum. And usually is oral hysterectomy, meaning actually like remove the ovary as well as the uterus. Okay, so those are actually like important. So therefore, there will be range of different anesthetic, and you want to take note of that. Obviously, like the first one, when you put in the answer here of xylazine, I mean, like I would have problem with use of the xylazine, especially like if the pyrethrum come in, they have some certain degree of exposure to the toxins. They may be possibly in septicemia. I don't think I would want actually like xylazine in the protocol, because it will even in healthy animals, sometimes it may also have create some changes in the cardiorespiratory system that may sometimes increase the risk for this patient, and like complication as well. There were a paper that looked into the various different type of like anesthetic being used, and definitely xylazine has been shown that increase the odds ratio, or the risk, the odds ratio of complications and possibly death by, I think, if not mistaken, is 10 times, if not 20 times. So meaning there's actually like chances of complications when xylazine is incorporated in anesthetic protocol. It will increase complications by at least 10 times the chance compared to others. So you need to take note of that. So I would recommend that, because xylazine is a very common, it's very useful. And when I'm saying this, it's very important, like you have to actually like take note in this. When I say be careful with the drug, it doesn't mean that it's not the same as the statement to say that this drug is not good. Okay, please do not actually like see. I say be careful with the use means that you need to know the effect of the drugs. How does this drug work? How does this drug affect on the cardiorespiratory system? So you need to take note of that. So therefore, if let's say it actually like for example xylazine, you need to know that these drugs, even at low dose, it can actually like create initially of like vasoconstriction onto the blood vessels, and then following that for a prolonged period, because it actually like depress on the CNS, and they will reduce sympathetic outflow, and therefore for a longer period, the animal tend to be in hypotension. So need to be aware of this. And because of that, therefore, in higher risk patient, such as in the pyometra, that may be presented with various degrees of toxemia, or even changes in the blood circulating volume and so on. So you probably want to reduce risk and not put xylazine in your protocol. Okay, yeah. So that's the things to actually like take note on here when I highlight the things called red color. So my recommendation is avoid in this type of cases. Even though the animal is presented to you, it looks, you know, like as if like happy and nothing happened, but you know that precisely there were pus coming out from the uterus. It means that it has an infection. So your ASA class is not class 1 anymore. It is at least class 2 and above. All right, so your risk is already higher. If your risk is already higher, so you want to use like drugs that have less cardiorespiratory depression on the cardiorespiratory system. Okay, so avoid xylazine. Even with acepromazine, you see that? So even with acepromazine, so if the animal, for example, come in and the presentation is that the animal is depressed, it have not been eating for at least 1-2 days. In fact, it's so sick that it started vomiting, you know, that kind of like presentation. There's no need to pre-med with acepromazine, so you will avoid that, okay? And so that's why I highlight that yellow color, that that's where the textbook says you don't even need to sedate the animal if the animal is already depressed. So to take note on here, okay? Other than that, you see that actually like in terms of the anesthetic protocol, right? Some of the principles to actually like know is actually like if you have an animal that is actually like in terms of cardiovascular in terms of blood pressure, okay, if possibly they may be low possibility, if let's say we put an anesthetic, their circulating volume is not that adequate and maybe blood pressure may drop. So this type of condition, then usually we avoid acepromazine in the pre-med, okay, because acepromazine, there's no reversal, and then we know that acepromazine, it can bind on the what do you call that, the blood vessel, and it can actually like cause vasodilation. And the effect on the vessels, the vasodilation can persist for many hours. So, you know, like if you want to play safe in some of the patient that actually where we are worried that blood pressure may be difficult to control under anesthesia or even during the early stage of the recovery, then we avoid acepromazine. Okay, but again, that doesn't going to come up with, you know, like this where I find some practitioner or even students, you know, like you tend to go very when somebody says something like this, then you lean on all to the right side, meaning no ACE at all in all cases. But that is not the way, because acepromazine is very useful in healthy patient, in animal that is easily stressed, in animal that is easily worried or actually like apprehensive with the whole environment. Acepromazine is useful. So if you're not worried about actually like blood pressure, because not all animals have that kind of like condition. So even in older patients, if they are tend to be very tense, so acepromazine actually play a very important role, and we should include that in the pre-medication. Okay, I hope you actually like get that. So whereas the use of like things like midazolam, diazepam, so this is the group of tranquilizer, okay, that actually is well known not to cause much effect on the cardiovascular. So we call it as cardiovascular friendly drug. So it will not really change the contractility of the heart. It will not really cause vasodilation. It actually like have some, you know, it quite have little effect on the depression on the cardiovascular system. If you use a lot, the animal get more sedated, and then sometimes it may have respiratory depression. Maybe the animal gets sedated, the respiratory rate may be observed to be slightly reduced. But that's what you tend to see if you give more anesthetic drug. When the animal is deeper into anesthesia, their respiration will also reduce. So therefore, midazolam or diazepam is a drug that, you know, like to consider included in if you are worried about actually like cardiovascular effect of other kind of like sedative or other kind of anesthetic. Okay, but of course, if you include this comparatively to aspromazine, this drug is more expensive. Okay, may not be so easy to get. All right, and then these drugs are also a control drug. I mean, like aspromazine is also a control drug, but the degree is different. Okay, now aspromazine under the poison list, Malaysia poison list, is not within the third schedule. So if you remember your pharmacology, third schedule means this is the psychotropic schedule. So the legal requirement for this is that so any drugs that is actually like in the psychotropic list, so they are what you need to do is that this drug must be put into a safe, so it must be properly controlled. It's actually like in the safe, and the safe is in a closed room. So is that mean you have double protection, all right? And it is only used by authorized people. And who is the authorized people? Authorized people is only either it is a doctor, okay, a veterinarian. If not mistaken, another one would be the dentist. So doctors, okay. So it may be actually like going to be can be you have like a nurse that actually like administer this and so on, but the ultimate person responsible will be the veterinarian, the doctor, the medical doctor, or the dentist. And you are the one who we are the one who have the authority legally, all right, to actually like prescribe and prescribe this. So, and what is required with this is that, as I said, one is actually like in the safe, and the use is actually like need to be recorded. Need to have a book, and then need to be actually like recorded what's in the safe, how much is being take out, to whom is being administered, how much, all those things need to be recorded. Okay, because this is the drug that can be abused. All right. So therefore, with this, then that means actually like there is increased regulation and work that need to be done when you are using with this drug. So whereas compared to aspromazine, it's actually like it doesn't need to be recorded to the same degree like midazolam or diazepam. Okay, so that makes that difference. But the cost-wise is a lot of difference. Okay, then you'll have actually like the next one that you talk about the use of opioids, hydromorphone, morphine, buprenorphine here. These are opioids. So opioids, again, all these opioids is the same in terms of legal requirement. It's the same like midazolam, means actually like it is also listed in the third schedule that require all these safe in the safe and is under control and so on. Okay, not only that, in Malaysia, it is also regulated under another act, and that is known as the Dangerous Drug Act. Okay, because it's actually like even more dangerous that not only it actually can be abused, but it can be actually like sell off, involving. So they put this in the other act so that the police are also in control. And then if they are suspected of actually like smuggling or actually abusing it, police can come in and say they want to actually look and what do you call that, ransack your practice or actually see and so on, that you're suspected of anything. So they have the power lah, because it's actually like permitted under the law. Okay, so to think note of that is actually like this type of drugs is actually like under regulations, and if you are actually like having it in the practice, you need to follow the law, what is required in terms of purchasing, keeping it in storage, and who can take it out and who can use it and administer, so on. All right, so those are the things to take note. Okay, your friend Dwayne just now talked about actually like bradycardia. Like I don't think actually like pyrethrum is, like meaning like bradycardia will occur in, like most of the time associated with pyrethrum. I don't think that is the case. Like pyrethrum can happen in all cases. And that condition of pyrethrum, you know, like I don't see how it can link to bradycardia actually. Okay, but the general terms of saying that administer atropine if bradycardia occurs, that is a very general, and then it applies to all cases. Any cases that actually like if you have bradycardia, or if you worry that bradycardia is like potential, you can use atropine as a prevention. So it's actually in the pre-medication. Or in this case here, if let's say it happened after you given certain drugs and you see bradycardia, then you can give atropine. I guess this statement here refers more to because if the animal has been given the opioids, the one that's listed here, such as hydromorphone or morphine. So these are the drugs kind of like more well known that have a tendency to cause, to result in animal to have, slightly lower heart rate. And therefore, like if after you given that opioids, you see bradycardia, you can easily overcome that by giving a dose of anticholinergic, such as atropine, or if it's overseas, you have a glycopyrrolate, you can use the glycopyrrolate. So that would be a treatment. But if you, let's say, foresee that it would be a bradycardia and you do not want that to happen, you can mix that together with the opioids and administer it. So that would be a pre-medication. Okay. So the induction here again, ketamine, xylazine, or propofol. So my recommendation, stay away from ketamine, xylazine. So you can use ketamine diazepam. You can use ketamine midazolam. You can use propofol alone. Or if the animal really not stable, then sometimes, like don't use propofol alone. That's why you will hear people using things like you have propofol, then at the same time you have midazolam or diazepam. So that will reduce your propofol. You don't need to give it as a bolus. Some people use like give a bit of propofol, then they give a bit of ketamine. So that will also reduce that propofol. So why do people wanting to go to that type of like, why want to mix so much drugs like that? Basically, it's actually like, so in general again, so propofol on its own, to get the animal induced, maybe it will actually require slightly more volume, but it depends on how you give it. So if you give it as a whole bolus, so the huge amount of propofol given as in a short time, sometimes it can cause the animal to go to apnea. And if you give also as a bolus and too fast, sometimes it causes vasodilation and the blood pressure drop. Okay, so it may actually like cause that. So so to prevent that, either is actually like if the animal is actually like like normal volemic, it doesn't have issue with the heart or with its blood vessels. So giving propofol on its own shouldn't be a problem. So and if you see that they would actually like put a certain dose, you follow that dose and titrate to effect. So the animal should be stable. So using propofol alone is possible. But if you want to reduce that, then people will give like a bit of propofol, and then they give a bit of ketamine, and then they wait a bit. So this drug have a chance to go to the brain and depress it. So as the animal go deeper, and when you test the jaw is actually relaxed, you can intubate it, then you achieve that. So then it will result in actually like reduced use of that propofol, and hopefully that can keep the animal cardiovascularly a bit more stable. And after that, once you intubated, then you connect it to the machine and maintain it under gas anesthesia. So with the gas anesthesia, again, it may also affect, gas anesthesia itself also have an effect on both the cardiorespiratory system. In terms of actually like the heart, in fact, when you compare isoflurane to propofol or ketamine, isoflurane itself, like it will have vasodilation, so it causes the blood pressure definitely will drop. It will also reduce contractility, so the heart pumping activity slightly reduce. So your blood pressure definitely will actually like drop. But then you may ask the question, then why use isoflurane? Why not use propofol? Yes, you can. If you want to actually like just use propofol alone to maintain, so you will need a lot more propofol to maintain. So that's actually go as what we call as TIVA, TIVA, total intravenous anesthetic technique. that you can actually like go on that, but you need that volume, all right? But again, depends on how long is your surgery. If it's actually like so long, you will need to make sure that you require a lot more of propofol. And then if it's actually like happen to be a cat, then you're also worried. If actually like using too much of propofol, you may end up having other problems when you know, like, because cats, you know, they have some problem with their metabolism, and then they may end up with some development of some other problems, such as their, because you know, like it's related to formation of Heinz body, and then they may be actually oxidative stress to the tissues in the cats, so you end up with those problems. Whereas with isoflurane, we know that actually like very little amount of isoflurane is being metabolized by the body. So whatever being actually inhaled, as long as the lung is functioning, it can actually like continue, you know, like ventilate, you will exhale. So what is inhaled, once it's exhaled, the animal wake up. So the control of the anesthesia is much better with the inhalant. The animal can go down once it actually exposed enough of it. And then, you know, when surgery is done, you turn off the vaporizer and continue to ventilate with oxygen. And once actually like adequate of the isoflurane been exhaled out from the lung and less in the blood system and also the brain, as a matter of time, the animal will actually like quickly recover from the anesthesia. So it's more like because of actually like the ability of you to control in and out from the isoflurane. But of course, if you just rely on isoflurane, of course, the amount you need will be higher, right? So, and when you have too much of the isoflurane, then you have that problems of what I said just now, vasodilation, as well as the reduced cardiac contractility. So your heart, your cardiac output reduced, blood pressure actually is dropped. So that's why then actually like in the use of like anesthesia for, so we always tend to, you know, like combine it and make sure it's not just maintained with isoflurane. That's why in the pre-medication we may have add on, you know, like that midazolam, and more important is actually like we put in opioids. So the opioid itself provide the analgesia. So as in the pre, intra, as well as post-operative period. But more importantly, intra-operative period, if you have the opioids for the analgesia, then the what we call that, it will also have this another terms that you have learned, MAC reduction. It will reduce the minimum alveolar concentration requirement of the isoflurane to maintain anesthesia for the surgery. So because you require less of that, then you have less cardiodepressive effect from the isoflurane. So that's what we call as, you know, like another terms that call that as balanced anesthesia. So meaning actually like to maintain the animal is not just the isoflurane, but you have that background of perhaps if you have sedated with the midazolam, you have the background of the midazolam, and then you have the background with if you are given it some morphine or buprenorphine, you have that. So then your requirement of the isoflurane setting is much reduced, and therefore then that will have like less cardiodepressive effect from isoflurane alone. Okay, Kevin here asked the question, what if we use TKX? So TKX is also the same. So same as ketamine xylazine. How is that so? Because you have the xylazine component in there. You may think that actually, I mean, you may say that, you know, perhaps in the TKX, because you have the tilatamine zolazepam, ketamine, and the dose of the xylazine is not as high as compared to if you're using ketamine xylazine alone. Yeah, it's true. Your xylazine dose probably is actually less, but there are also texts, and also, I think, if not mistaken, there are already research that have actually like done, but I can't exactly pluck out exactly what is the dose, which show that actually like whether the xylazine have been given as a low dose, I think as low as even 0.2 milligram per kilogram compared to the usual dose that is used between 0.5 to 1. The cardiodepressive effect from the xylazine in there it's kind of like comparable, at least for the immediate administration, once you give it IM or IV. So, you know, that immediate effect is there. But of course, if you actually like give less dosage of this xylazine, the sedative effect won't be so prolonged. So meaning actually like, for example, if you use your xylazine dose is just like 0.2 milligram per kilogram compared to if you use 1 milligram per kilogram. So the time for the animal being sedated, it's not going to be as long as, you know, like that given the low dose compared to with the longer dose. That is actually in terms of the duration of the sedation. But in terms of actually like ability to cause the cardiorespiratory depression, the immediate one, the moment you're given that, and the degree that it can press on, you know, like depress on the contractility of the heart is most similar. Okay. I just remember, sorry, it's probably not on xylazine because it's a lot of work done in the early 2000s. It's more with the medetomidine, which is another type of alpha-2 agonist. So in general, we note that actually like the alpha-2 agonist does have data of cardiodepressive effect. Okay. Any more question that or things that you don't understand from this? Okay. Dwayne asks, doctor, if say a very severely dilated closed pie mitra causes compression to the surrounding organs, would it cause bradycardia? Yes, possibly it may be actually like, so are you actually like trying to say that it is because of the compression in the visceral organ that caused the bradycardia? But honestly, actually like you know, we have actually read in the textbook saying that actually like when we are doing oral hysterectomy or we applying traction to the visceral organs, that sometimes we may elicit the vagal response. So we actually elicit vagal response and then there will be bradycardia. So I think I also have read this in textbook saying something like that, you know, like, you know, when you are doing procedure involving with the visceral organs and then but it's to me it's more like traction, isn't it? So but then when I see the real one, when we are doing traction, actually I see tachycardia, or maybe it's not tachycardia, I see increase in heart rate instead of like decrease in the heart rate. And I've been actually like putting at the back of my mind about this actually like whenever we say apply traction and so on, but honestly, clinically and even in many practicals, I actually have not seen, you know, like a bradycardia or actually a stimulation of the vagal reflex when we you know, like handling and mugging around in the in the visceral organs. Okay, so this part about compression to the surrounding organs, I'm not sure that I've read something like that, but Dwayne, if you have read, so perhaps you can actually like share with me and CC to the whole class if you find a reference they say that. Okay. So in general, I don't think I've seen that lah. Okay, thank you. So yeah, whatever you found, if you found, then actually like if you have not found and you say that you have actually searched through whatever search you have done and you have not found, then please update us as well. Okay, thanks, Dwayne. Okay, we move on to others. Okay, I'll just actually like take note on here. This one here. Okay, I highlight in pink color about meloxicam, ketoprofen. So the reason why I kind of like immediately highlight on this, this is again in general. So in general, again, when we talk about the use of non-steroidal anti-inflammatory drugs such as meloxicam, ketoprofen compared to meloxicam, I think it's not as a COX-2 inhibitors. I mean, not so specific compared to meloxicam. So the safety margin possibly actually like even less. So in general, things to ask, you know, the question that I always make it simple for people to actually like remember about the use, the perioperative use of non-steroidal is such that first thing ask, are you concerned about bleeding issues? Are you concerned about, like renal issue? Are you concerned about GIT? Okay, so is there any precautions or contraindication in the use of this, drugs in the perioperative period? So this would be the three things, because we know that actually in terms of NSAIDs, things to be careful is actually like, as I said, all right, but it doesn't mean that actually like you cannot use it. It's just to be actually like take note into the condition of the patient. Is there any other thing that will preclude the use or need to be careful? For example, so like if let's say in terms of OHE, and if let's say it has been, it's a chronic condition, the kidney somewhat has been actually exposed to the toxin and has somewhat show some, renal damage. And then if let's say the circulating, okay, the fluid deficit, the dehydration is not appropriately reversed yet, you have not given the replacement fluids adequate yet. So if those things are still not corrected, then to be careful with the use of the non-steroidal anti-inflammatory drugs. So in general, the fluid deficits, okay, fluid deficits in these patients, whether it's pyrethrum or in any other associated, it need to be corrected. So if it's corrected and then you are no longer worried about shock, you no longer worry about inadequate circulating volume, whereby it is may further compromise actually like perfusion to the kidney. So if those things already, you have addressed it well, so it should be okay to actually give the non-steroidal. But if the animal, is still dehydrated, after the surgery, if you are able to actually like measure blood pressure, if let's say is still low, so you want to address that first before you give the meloxicam, so that you would not later be blamed for actually like further causing more renal damage to the patient. Okay, so if you ask me actually like would I use, if let's say the animal is really in pain, and or maybe actually like during the operation I have performed a lot of tissue manipulation, and the animal possibility will have a lot of inflammation in the post-op, I would consider. But again, same thing, my principle is the same. I will ask, am I going to be more continue to be concerned about bleeding post-op? So if not, then okay. Most of the time here, we are very good. We already have, make sure we have IV access. Animal definitely to be continue with fluids. So, and I have actually like replaced most of the deficit. I should be happy to actually give them Roxicam. Okay, but it would be actually like a different, if let's say, but it shouldn't happen to me, because right now, after you've gone through this, you should actually realize that this is a pyometra case. So in fact, you must have an IV access, and you must already put the animal on fluids. So at least some fluids should have been, pre-operative fluids should have been infused to the animal, and in fact continue during the surgery. And in fact, post-operatively, usually this animal may not eat immediately. They may not even drink immediately. So you need to actually like support the animal with some at least maintenance fluid. So, and that would at least like to ensure that you will have continue to have good perfusion to the rest of the organs. So with that, so usually it should be safe. And if it really require, we'll go ahead and actually give that dose of meloxicam if it require. Okay. So Kevin asked about what about tramadol? Yeah, we use it a lot. I mean, I would use it a lot. In fact, if let's say I have enough tramadol, and the tramadol can control the pain, and then I may not immediately start meloxicam. So I think tramadol will be helpful. You may have actually like heard now in private practice, or even some in overseas, or even in actually like what people talking about tramadol not adequate for dogs, and there were questionable efficacy of tramadol in dogs. I agree that actually like tramadol is not as effective compared to pure opioid such as morphine on the control of pain. But then again, as you come into clinical practice, you will start to actually like, I hope you will start to actually like pay more attention and actually like see, things are not in black and white. Okay, it's neither like only to the left or to the right. A lot of things is between. Okay, you can have actually like, that's why always remember in biology. Okay, remember on your statistic, things always come in a bell curve. I mean like the distribution. You have actually like some certain percentage is more extreme to the left or more extreme to the right, but majority of it sometimes it may have some screwed slightly, but there will be actually majority maybe actually like in the middle, but there will be always a range of actually like things. Okay, so and in between, that's why we say that actually like tramadol is not necessarily say that if you say that you have less efficacy, then you just chuck away the drug. No, it's not like that. Tramadol still have its use. It's just that you have to learn to how to actually use it, knowing in what kind of like condition and the dosage that you use. So to me, if let's say it's just a pyrethrum, is a soft tissue injury, the degree of pain that associated with this is somewhat slightly like just like oral hysterectomy. So I will classify this again. Sorry, it depends on uh, uh, surgeon. So sorry, I'll just say this. So if let's say, like I get a student, like a novice person who not very good with their surgical skill, if they are the one who perform this OHE, I maybe have to use more drugs lah, because your tissue handling is not as good as a delegate and a very experienced surgeon. So there will be more tissue trauma. And when you have more tissue trauma, so this patient in the post-operative period, they will experience more pain. So your tendency is you may need to actually like have a bit more pain control and so on. But compared to actually like experienced surgeon who are very good with their tissue handling, very delicate, very careful with their tissue handling. So you see that actually post-operatively, most of the time, this animal, the level of pain is actually less. So then the type of drugs used is actually less. And I find that actually like in my work in oral hysterectomy, when I have experienced surgeons that is doing it, I rarely actually like tramadol alone in both cats and dogs has been adequate to control the pain. Even with actually like one dose itself in the pre-medication, they can tolerate the pain. But of course, if we can actually like have like the second dose, it makes the animal even more comfortable. Yeah. All right. So that's actually like with the use of tramadol. So to answer your question of actually like tramadol in pyrethrum case and for dogs itself, I think it's able to do it, but not just one dose. You still need to actually like know what the dosage, and perhaps like redosing it every every 4 to 6 hours may be necessary to achieve the analgesic required, at least for the first 24 to 48 hours, and then later on you can taper off the tramadol. Next question. What is it? Can you give steroid perioperatively? Steroid, okay. So if you're actually like looking from the standpoint asking this question that steroid as an analgesic, I have actually like no experience using steroid as an analgesic. And if not mistaken from my reading, actually steroids actually like some texts may actually like even classify as an analgesic, but the mechanism for steroid compared to non-steroid, okay, from non-steroid anti-inflammatory drug is slightly different. Their mechanism is slightly different. If you're actually looking into the mechanism of analgesic, is based on anti-inflammation. So steroids may have a role to play, meaning actually like it reduces the inflammation and therefore may contribute to pain relief in the post-op period. But non-steroidal may have other type of mechanism that can confer analgesic in that way that it is slightly superior. But our concern about the use of steroid as an analgesic is the side effects associated with the use of steroid. So, and again, so in general, I think we know that actually, like again, of course, steroids, I'm not going to go into the details here. So I hope that perhaps Amma, if you are the one who asked this question, can you go and actually like read up about steroid? One, what are the type of steroid? Two, even within the glucocorticoid type of steroids, there are different types in terms of the duration of action, and yeah, mainly is the duration of action. So if the longer duration of action for those, what would be the expected side effects of the steroids? How will it affect your HPA? Okay, the hypothyroid, is it hypoadrenal cortisone axis, something like that. Okay, so those are the type that actually like to take into consideration. So I am not sure. I think usually if let's say you're talking about short acting, and then one dose steroids, maybe like the side effects that you can get from steroid is not as bad as if you look use a long acting such as a dexamethasone. But in general, like we don't regard the use of steroid as a routine use like non-steroidal, okay, because of the associated side effects from the use of steroids. So therefore, we don't do that. But we still need it in some circumstances, such as if we are looking for anti-inflammatory effects. Okay, not so much about the analgesic effect, but the anti-inflammatory effects that may cause more problems, such as, for example, let's say we are dealing with surgery involving the respiratory tract, okay, maybe involving the trachea, okay. So the trachea, when you're actually handling the mucosa and so on, they are quite prone to actually like inflammation, and when they are inflamed, it can actually like cause swelling, and that swelling itself can in the immediate perioperative period can obstruct the airway. So if that is the case, then that's why then there is an indication to give the steroid either in the pre-med as a pre-medication to reduce the post-handling inflammation, or after handling and we see that, wow, okay, inflammation starting to set in, we try to, if possible, reduce that, and then we use steroids. So that's actually like like is indicated and have a justification to use the steroids. But when we use that, it's not because we want the analgesic effect, but because we want the anti-inflammatory effects that may cause have some immediate risk in terms of actually like animal ability to breathe and all that. Okay, yeah. So Amar, you can actually like also please read up about steroid and then share about adverse effect of using steroids. Yeah. Okay. All right. So again, that means actually like I put here the point is actually like to take note on your pyrethrum. So main thing to remember that is actually like because of the sepsis and shock, this animal can be cardiovascularly not stable, and you need to correct that before giving the anesthetic. Okay. The gray color here, I'm asking antibiotics therapy based on culture and sensitivity results. So I guess I want to ask this group again. So would you be suggesting that you only will start the antibiotics after you get your culture and sensitivity test? Group.
No, doctor. Usually we will just give a broad spectrum antibiotic and then we will monitor for 14 days before we change anything.
Yeah, okay, correct. So meaning actually like even in the pre-op, we probably would have started a broad spectrum. So and then and in fact actually like we may not even go to 14 days. So that's why the technique for the oral hysterectomy, I mean, or removal of the pyometra is very important to actually like to be actually like clean. But of course, if there's spillage, even antibiotics sometimes may not cover. So that's why it's very important to learn the techniques of like avoiding no rupture and all that. Okay. So, but if let's say there were some sort of like, like remnants, or there are actually like things left over, you may need to actually like have prolonged antibiotics. But honestly, based on experience, either like the job is done well, and then not much is actually like nothing left in the stump, or actually like in the peritoneal cavity. So even the standard seven days antibiotics should be adequate to cover, and we often don't need to go up to like 10-14 days. So that's based on what we have seen lah. Okay. Yuchi asked a question about how about papain used instead of non-steroidal. So okay, then Yuchi, then I'm going to ask you to actually read up and actually like what is papain. So in general, again, actually like papain is it comes from harvested from the enzyme from papaya, right? Okay, so basically how this actually works is that it is an enzyme, and it has the mechanism that may contribute to pain relief by breaking down proteins and so on that actually like that have occurred in the wound area that is about to in the wound area. So meaning actually like in the wound where you have actually like exudates been attracted to the wound and so on. So the aftermath of this all this inflammation, all the chemotaxis of things that are happening in the wound. So that's actually like they have a swelling and all that, and there's accumulation of all these protein leukocytes or dead leukocytes and so on. So so how this actually like proteolytic enzyme help is that, so if they reach there, then they help to actually like break down these bigger proteins and so on to smaller one, and hopefully when they are actually like broken down in smaller pieces or molecules and so on, and hopefully that can actually like help mobilize or being actually like removed from that area of inflammation better, and therefore results in actually like reduce inflammation or reduce swelling in that area of the wound. So, and with that may actually like contribute to pain relief. So that's how I see the way actually like it is useful. So can you use it instead of like non-steroidal? You say if it's instead, again, that's why I say it depends on the how, like what kind of pain we're talking about. So, same thing as well, if you say that, okay, if it's just oral hysterectomy, and we always like expect certain degree of like inflammation from the incision site. And then if it's actually like, let's say again, like it's performed by a experienced doctor, usually the swelling is also very, very little. And, if you do not want to prescribe NSAIDs, that's fine. Papain, yeah, I mean, like it really costs no harm. Is it better than if you don't use papain? Sorry, I have not done the study to compare. I'm not sure whether like it make a difference. Based on what I've seen so many, I think if the surgery is done by a experienced surgeon, uh, and you have actually like tramadol in the pre-med and maybe another dose in the post-op, if let's say I compare to another group that I add on papain, most likely I think that's not going to make a difference. Most likely, okay, that's not going to make a difference. If I compare a group that is actually like again same done by an experienced surgeon, one just have like the tramadol, another one is tramadol together with an NSAIDs, would I see a difference? Most likely yes. Perhaps in the later part, we may see some slight difference. Their pain score is slightly lower, and that's based on just like the limited number that I've done before many years ago when I actually like tried that. And I do see that actually like animal that is given the adding on and non-steroidal, their pain score, their return to normality is faster compared to the group that just have tramadol alone. Yeah. So NSAIDs, like would you say that then why not just use all NSAID? That's why I say as long as you know, like, yeah, the patient, there's no contraindication, you can use it. It have its role to play. Okay. All right. So hopefully with that background, you guys kind of like have like some more, revision of this background. So with this, hopefully we can go faster. Okay. Right. Cesarean group. Anyone from group 11, 20 want to just quickly highlight what would be the associated condition or pathophysiology to consider for anesthesia? Group 11 or 20?
Doctor, maybe I can try to summarize the cesarean.
Okay, go ahead.
Okay. Okay, so actually cesarean, there's two important things that we have to take note of. First is the health of the pregnant female, and the second is the fetus. So first one, the pregnant female first. First, we have to make sure the pregnant female is in a good condition. So make sure it's in good condition is to avoid any bad prognosis and any bad complications after the surgery. So before surgery, you have to check whether the pregnant female has dehydration. If it has, you can treat with IV. If it has electrolyte abnormalities, we can treat as IV as well. If it has hypovomic shock, we can treat with isotonic crystalline fluid. And if the pregnant female have a decrease in calcium due to hypoxic skeleton of the fetus, we can treat with calciferol or something like that. So we have to make sure it is in good health. So another side for the fetus, we have to make sure the drug we choose is good so that it does not hurt the fetus. So we have to choose the drug that is does not cross the placenta rapidly. So example like drug like ketamine and espromazine we have to avoid because this type of drug is can cross the placenta rapidly. So besides we have to choose drug that is short acting and also rapidly. So induction drug like propofol is a good choice. Besides that, the anesthesia we also have to choose the anesthesia that does not depend on liver metabolism, also renal circulations, and it can be reversible by the antagonisms. And also we have to make sure the surgery procedure, the time is try to keep it as short as possible because we want to avoid and minimize the time the fetal exposure to this cardiovascular depressant drug. Yeah, I think that's all.
Okay, thank you very much. Anybody want to ask anything or disagree? Okay, I highlighted here pink color on actually like the pre-med with hydromorphine and oxymorphone. So it's just the same that you were saying that important to try to actually use drug because most of the drug that you give to the mother or to the dam, okay, to the queen, so it can actually like cross the placenta. So when you say that actually like you're going to use hydromorphone, morphine, so the target of this drug is to confer analgesia to the mother, mainly actually like intra-op and also post-op. So but then when you actually like give this, similarly you may actually like some of this drug may actually like cross the placenta and it can go into the fetal circulation, and then once the fetus is actually like born, and so like has separated from the mother, and part of this drugs already gone into the fetal system, and therefore this fetus may be it will be slightly depressed out, like in once it's actually like born, and therefore either one you have the naloxone, which is the reversal to reverse that, or actually like another thing that you may have read is that what people do is they don't use this long acting pre-med. I think not mistaken whether like some of you have written and maybe another the dystocia case. If let's say like for the fetus, if you want to have the intra-op analgesia, then fentanyl is another opioid, which is short-acting. So you can consider, like using fentanyl as the intra-op analgesia. So it's shorter acting compared to if you're using things like hydromorphine or even oxy. They're longer acting in here. Either that, or the other things that people do is actually like they don't give these opioid first, but like to work quite quick to get the fetus out, and the moment the fetus is out, then only they actually like give the opioid. So some people can do that as well. But of course, if you do that, you are relying on actually just the anesthetic, and you're relying on things like propofol, isoflurane to actually like get the animal under GA so that you can deliver the baby immediately. And you may actually like need to use more of the isoflurane, and therefore some people may also say that actually like when you use more isoflurane, it can also depress on the fetus. So and that's why they actually like the part on how to successfully able to deliver a viable and active fetus actually count on not so much of just the anesthetic protocol. Actually, like it's the whole team that can be work very efficient and fast to ensure that actually like from the time we give the anesthetic to the time that it's actually like put on his dorsal. So don't forget that some of your friends also have said that like the moment you put the animal on his dorsal, the whole gravid uterus is going to press on the vena cava, and you're going to have actually like a reduced venous return to the heart, and therefore the cardiac output is going to reduce. And when the cardiac output actually like reduce, so over time there's going to be less and less actually like oxygenated blood delivered to the placenta and the circulation, and the fetus when actually like deliver is going to be actually like less viable. So it's very important from the time the animal is kind of like the moment you put it on its back, it's going to be like cut into the abdomen, cut into the uterus, get the fetus out. It's within a short time. So the thing here, the secret actually like, the secret recipe here is about how fast we can actually get the fetus out the moment the animal is induced, put on its back, and actually get the fetus. The longer, like the time taken that the animal have gone on his dorsal for it to actually like for you to get the baby out, the less viable will be the fetus. Okay, I still remember that actually like when I was working as a resident in Guelph. So after all the discussion and all the preparation, we were actually like have prepared and so on. With one actually like experimental, I mean like they were actually like have got like a sort of babies from, I think it's a project that they will do. So but the protocol that was discussed was actually like to me was ideal lah, like it was use of like no opioids, and then opiate was just ready for the moment the baby is out. So all that being taken into consideration, only using propofol and then isoflurane. But then when they were doing that, as I see the way it's been done, and I just didn't have a good feeling because it was just taking too long. So the moment when it's taking too long, at the bottom of my heart, I'm just like, wow, okay, I really have to see this and actually like see how they deliver. And in the end, guess what? They managed to get some babies out, and then initially they don't really look very well, like even after when they actually deliver, they would look very weak and so on. And then in the end, honestly, like everybody was so sad because all the baby died after that. And that was because like after I looked I said, wow, I mean like it takes them nearly more than 1 hour before the babies come out. That's very poor prognosis. So that's the main thing to actually like like I want to emphasize here. It's actually like how you can organize and the speed from actually like the moment the animal is induced, that you can as quickly as possible get the baby out. So sorry lah, please come back to the surgeon. Surgeon, please, if you're going to be a surgeon, then have to be very organized. It doesn't depend on just the anesthesia. Okay, right. Okay, some of the things you can read here yourself. Okay. Dystocia, I think more or less about the same. I think main thing in here with the dystocia, obviously, compared to the one that is elective, is that dystocia will be a bit more challenging because obviously the animal already gone into labor. They have actually like, I'm not sure how long they've been laboring. So the longer it is, the more derangement in terms of fluids and electrolytes, including the glucose, possible glucose as well, and calcium that you need to actually like take into consideration, because sometimes if they are dystocia because of actually like a lack of calcium, that's also something that need to be checked and corrected as well. So it's more challenging in dystocia cases. And I think one of your friends also say here, if let's say it has been prolonged and the fetus start to die or decompose, so you may have actually infection going on. So animal, the mother itself may be also in septicemia. So this is actually again more challenging. The principles behind this the same as what we discussed about the pyrethrum, but in dystocia, you will expect even more derangement, and you need to actually like try to look for this and actually like correct as much as you can before you know, pushing the animal under GA. But of course, you don't have actually much time. It's not something that you can delay and do the next day. No, you have actually a dystocia. Sorry, it's an emergency. You need to address that ASAP. Okay. I just want to actually like ask here then, since you write here, what does a short-acting opioid epidural means? Not sure. Group 9 lah. Group 9, somebody want to answer this question?
Hello, doctor. So for this one, the short-acting opioid epidural is actually, if I'm not mistaken, is fentanyl.
Fentanyl, if not
Yeah.
mistaken, is that something that you have from the text itself?
Yeah, it's from the text actually.
It's a textbook?
No, it's a article that we got it online.
Oh, it's an article that you got online. Okay,
Yeah.
I see. All right. I guess, I mean, like they have the argument here is because they want to have like the short acting of the fentanyl lah, meaning actually like they want fentanyl. So in case some of this fentanyl from the epidural space have been absorbed into the blood circulation, that if we have actually like also passed into the fetal circulation, that it can be actually like short acting lah. But then again, if they're going to go through the trouble of doing an epidural, right? To me, is actually like, you know, epidural, doing epidural technique, it's not easy, and often we can't get away, you know, like without having some sedation on the animal to do the epidural. So and that's why then I think I mentioned before, is it in your same group last semester when we discussed this? I did mention that actually like in the textbook, they have actually like given a few type of protocols that you can use for this cesarean case, or even like dystocia. And one of it is actually like the use of epidural. But I did mention to you that actually like, I think it's a most possible, but then the animal have to be, you know, like quite still and quite sedated for you to do the epidural. Because epidural is not easy to do, and the last thing you want that is that when you're introducing the needle, the animal move and you know where the needle have actually like gone, and you are going to epidural space. Obviously, most likely you won't be hitting any you know, like no spinal cord there lah, but then there will be actually like spinal nerve and running, and you may be hitting on actually like the sinuses, and it can have cause bleeding. So it's not actually like simple subcut or iron injection. You're talking about epidural here, so it's not easy to do. So therefore, you know, like you know, and if it's, since it's not easy to do, if you're going to able to do an epidural, to me it make more sense to actually like use a drug that can remain there for a longer time, such as, you know, like probably should be using morphine instead of fentanyl. And that can give like a longer duration of action for your post-op analgesia. If you're going to go, you know, that trouble of doing the epidural, instead of like using a short-acting opioid, then I think you should be using a longer one that can actually remain there and give that the post-op analgesia, intra and also post-op analgesia. If it's going to be actually like using fentanyl, I think I have no problem if, let's say, the fentanyl is, like given as in the IV, because it's so much easier in terms of that lah. That's in terms of cost effectiveness lah, of actually, like, if you have experience doing work, you will actually like compare which one is easy, and then it is actually like cost effective in that way. Okay, that's my comment on here, on this notes here about using fentanyl for the epidural.
Okay, thank you, doctor.
Thank you. Okay, next one got some more question. Gray color. What do you mean by actually like using inhalant, then got slowly increased vaporizer to 5%, da da da?
Doctor, this one is actually there was like a grammatical mistake like that, but actually what we want to mention is the 5% is like to let the animal be in a deeper sedation plane, and then after that we maintain on 1.5 to 2.5%. There was a little mess up here, and then it was not written correctly in the document.
I see the way actually, like when I read that, I think you may have actually copy paste from a description about induction with mass isoflurane. This part here on slowly increase vaporizer setting to 5%, and then with starting with that, and increase 1% every 20 to 30 seconds, and if excitement occurs, increase to 5% quickly. That is actually like statement and usually description about mass induction using gas anesthesia, using inhalant such as isoflurane. Okay, so you may have actually copy paste from there, and I want to say that, so if you're thinking about actually like that is an induction in a case of a dystocia case, I think it's actually like maybe a bit to me is actually like the cons, like the cons against this is that, as you know, actually like in pregnant animal, they may be more prone to vomiting, and like they're more prone to vomiting or regurgitation. That's number one. And then second, if let's say they have the gravid uterus, so like the abdomen is actually like a bit dilated, and this gravid uterus actually can be pressing against the diaphragm, as the way it's been described, previously as well. So when they're actually like depressing the diaphragm a bit, so it make the animal actually like, in terms of if you want to attempt induction using gas anesthesia, it is not a good choice, because the animal actually like, one thing, the ability of the animal to ventilate and take in isoflurane isoflurane is going to actually like take longer time. All right, it's not that efficient. It's not that efficient in terms of trying to mask, because the volume of lung, okay, or the lung to be able to actually like ventilate and take in the isoflurane is less compared to actually like a normal animal. So in this case here, the animal will actually, in fact, may take longer time. I do see that actually, like one of you say that they, like this patient may actually like induce faster. So, but it may actually like also take longer time, depending on whether it's like depressed or not, the animal. So on these 2 points, which is one, they may be prone to regurgitation. Second is that they have actually like the displaced diaphragm, and maybe a bit more difficult in terms of mass induction, that make this choice of induction with masking isoflurane something that probably you like think twice about using it lah. So the better choice is still getting an IV access and using a injectable to get the animal down, intubate it, and then go from there. Okay. Still have actually like, so what does actually like local anesthetic to infuse the area, and then you actually like give a dose of like infused pre-surgically at 2 to 4 milligram per kilogram per hour. How is that done?
Doctor, this one, according to the document, it is like the local anesthetic is inserted at around area of the midline incision site, and then it is used for surgery after surgery as a pain management, according to that document.
But then why is there Meaning actually like you mean you have like a catheter insert in that area, then after that it's been
No, it's
sutured
like
up.
with injectables, just inject around the area like that.
But then why is it having a rate? Because you put there 2 to 4 milligram per kilogram per hour. So when you whenever you write something like you got a dose and then some more got the rate, meaning actually like per hour, it means that that is a CRI. CRI stands for constant rate infusion. So it's not lah.
No, no, it's not. It's actually a mistake there. Sorry, doctor.
Another mistake, okay.
Yeah.
Okay, so basically what you say, so then perhaps you should want to correct this, and you're talking about just getting the lidocaine at whatever is that volume or the dose, and it's just actually like, meaning it's just like line block lah, or you just
Yes, it's
infiltrate.
something like line block according to the document.
Line block or infiltration lah. It's not just when
Yeah.
you write 2 to 4, you know, that kind of that is known as a CRI, constant rate infusion. And usually that refers to IV, intravenous infusion.
Okay, noted on that, doctor.
Okay. What else? Okay. Oh, this one is actually like quite good here. Of course, then you are given some details here about doing a fetal heart rate using ultrasound. So just want to ask then, actually, like this is also from the article, right? Is it you say that if it's less than 180 fetal distress, if you go further, you need to have urgency section. So what is the normal fetal heart rate? And this one refers to what species?
Hello, doctor. This one I took the part from BSAVA manual.
Mm-hmm.
So, the normal heart rate should be around 180, and but I'm not sure whether is it okay to take in the dystocia cases because it's already an emergency. So probably you might not have to take ultrasound.
Oh, okay. Thank you. And then do you, is this refer to both dogs and cats?
Refer both dog and cat.
Okay, great. Thank you. So remember, we all try to remember. Okay. Okay, sorry, I can't highlight here because I don't understand. If fetus were not stable enough to allow pre-surgical procedure, an opioid epidural can be given after surgery for post-surgery analgesia. Can
Doctor, this is I mentioned it because it's like if the fetus is not stable and you have to surgical as soon as possible. So actually, just to avoid, they decided to give the anesthesia post operative. So they just do
okay. The rest understand, not now that when I read again, then I understand. Okay. All right. Meaning actually like here it's actually like advocate the epidural opioid. So and the epidural opioid, which is mainly again, it's really helpful for post-operative pain. But I guess it's also not easy to do as the way I was discussing just now. And since you know like fetus not stable to allow pre-surgical, I think you said that it's actually like a pre-surgery epidural code. Is it? Is that what it means? So if the fetus not stable to allow a pre-surgical epidural injection, then to try to do this after the surgery, that you try to put in a opioid epidural that is to confer for post-op analgesia. Okay. Okay. All right. So the one on yellow here, so this is something to remember that actually like if you look at this NSAIDs, they say it's contraindicated for breastfeeding mother. Okay, so something to take note. Sometimes people forget about this, that actually like the NSAIDs. But again, there's also I think one of you write that actually like again some may have actually like minimal. You say that actually like it's minimal as well. So and that's why they say can just give once and probably that could be okay, right? Mm. This one here to clarify. So are you saying here atropine is chosen over glycopyrrolate?
Yes, doctor. Like,
Uh,
we-
atropine chosen over glycopyrrolate.
sorry, doctor?
So are you saying that we should choose atropine instead of glycopyrrolate because the atropine can cross the placenta barrier?
Yes, doctor. So that we can like increase the cardiac output of the fetuses.
Oh, okay. So that is actually like what the article says lah.
Yes,
Because
doctor.
I thought actually like another text that I read before, then they say actually like uh, should probably choose glycopyrrolate if you want to increase the heart rate, because then glycopyrrolate would not cross the placenta, and then we will not want to effect on the fetus.
Oh, okay, doctor. But in this case, I was referring to like we were referring to if the fetuses have like increased vagal tone, we want to increase the cardiac output, so we use atropine.
Okay. All right. So that means I guess it depends on the on the condition, like as you say, if let's say the fetus heart rate is actually on the low side and you want to actually like increase the heart rate of the fetus, then atropine is the one to use instead of glycopyrrolate. Okay. Thank you.
Thank you, doctor.
Right. Okay, we move on. Nobody have any. Okay. So the next one we talk about the blood cat and then requiring to do cystotomy. So this one here is a classic and you must know because it's very common. I think your friends have actually like mentioned in here. I have nothing much to say. So I just actually like cross in is actually like take note about the hyperkalemia, metabolic acidosis that should be corrected. Okay. The rest all you can actually like read lah. And then I already like mentioned in here. So all this, like in cardiovascularly in stable cases, that's why you say we avoid all these things like ACE, the alpha-2 agonists and so on. Okay, we'll just move on. GDV, GDV, anybody, group 4 or 2 want to actually like emphasize anything here?
Hi, Doctor.
Okay.
So I'm not really sure which points are really important to be highlighted, but I guess for the pre-op stabilization, it's really important that we ensure that the patient is given IV fluids and antibiotics to stabilize it before doing the surgical procedure, as well as doing the gastric decompression. And yeah, and when doing the gastric decompression, it's really important that we do it carefully so that we don't puncture or cause damage that can lead to like peritonitis or other infections.
Yeah, okay. I guess actually like yeah, all the important points has been actually like right here. So I get, like you guys to actually like read up about GDV. Not often seen, but depends on where you're practicing. And of course, GDV, just have to remember that usually happen in the deep-chested dog, like a German Shepherd, Great Dane. Yeah. So this probably will be the two species maybe we see more often here in Malaysia. If overseas, there may be others type that have, get the deep-chested kind of like conformation, this animal. And the typical history would be animal is fine and so on, may have some meals and all that. And then they were still active playing around, and then 10 o'clock, 11 o'clock, then start to call you and say that this animal have been retching and all that. Okay. And they may come with actually like gastric dilatation, may not have valvulus. So, but then when they come here, so main thing again, before we rush in to correct anything, usually when we go in actually like to correct is because if the animal have actually like have the gastric start to force, you need to actually like get in maybe to do the PEXI and all that. But other than that, if it's for decompression, decompression, like ideally should be done as a medical, meaning actually during the pre-op stabilization with the fluids going in and all that. Then what we try to do in terms of decompression is using the stomach tube. All right. So if can the group actually like try to see, search, like in the net, if there's actually like video or description of like how a tube into stomach tube, how to stomach tube a dog, okay, that have a GDV, how it's actually like been done. So that's important. I can share with you previously as first time when after I graduate and we were presented to such a case, like we didn't know about actually like how to actually like decompress pre-op, and in fact actually like rush into decompress intra-op, and that was really messy. But we were very lucky that actually like these animals survived with no contamination of the surgical site. So we were lucky. Then after we actually like seen it, it's like, oh my goodness, we have made such a big mistake. So never do actually like gastric decompression intra-op. We always try to do that if possible is in the as a medical emergency, not operating into the gastric but bypassing a stomach tube. So yeah, the rest of this year I think you can read lah, on actually like, so obviously it's actually like when you talk about this GDV, right? So the longer the time or the more severe is the dilation and volvulus, the more severe or the compromise is the condition of the patient when presentation and also under anesthesia. So, and then oftentimes once you actually like detorse, when you detorse the gastric, so part of the tissue that is actually like already started dying, they will release this kind of like cytokines from the dying tissues, right? So this sudden release of the cytokines into your circulation will cause a sudden drop in the blood pressure. Sometimes these cytokines also, like will cause injury to the heart tissues. And so therefore, if you put on the ECG, it's very scary to see actually like the ECG you will not be getting things like the normal PQRS complex, but it will go into ventricular tachycardia. So you see a lot of actually like big bizarre signs and so on. So, and then if it's very bad, then that's where sometimes like this tachycardia can be dangerous to the patient. But it's very common to see all this, and therefore I think your friends may have actually like written here, but strange that did you all actually put in, actually like nobody really put in here. Yeah, only this one here on the lidocaine. So at one time, most of the to actually like try to stabilize the cardiac arrhythmia. So you will see that actually like we can put the animal on lidocaine infusion. So and then this here got described here, when you put the lidocaine, there's always a loading dose and then continue on with the CRI on that. Okay. So this part here, they actually like say they put not just lidocaine but put ketamine. So, and this is also another type of like protocol. You probably may see us also using in clinics and cases. And the rationale for using both lidocaine and ketamine here is one is for MAC reduction, meaning actually like when you start on this CRI, you will reduce the requirement of the inhalant, the isoflurane. So therefore, in a patient such as a GDV, whereby their blood pressure will be, quite crappy, their heart contractility is compromised. So you want to reduce the requirement of the isoflurane, and therefore we add on, like lidocaine, ketamine. Not only that, we may put on fentanyl. So, a balanced type of like different drugs, so that we can reduce the requirement, the isoflurane. So it play in that role. The other one is both lidocaine and ketamine also has been studied. So more to ketamine for sure. At the sub-anesthetic dose, it also have a analgesic effect via the NMDA mechanism. Okay, it's an antagonist. Okay, antagonize on the NMDA and can contribute to pain relief. So that's why then that is the justification to include this in cases. All right. Other than that, like the use of, when you see this analgesia here, these are all the various different options that you have. It's not using all, it's just like the different options. Obviously, if you're using fentanyl, then you have to put on a CRI. And in terms of cost effectiveness, is that it's the most ideal, because then like when you use a fentanyl CRI, it means that it's you can control it minutes to minutes. So the moment you think it's actually like the animal is getting better, you want to stop it. And when you stop it, you probably would see the effect wane in about 1 hour plus, like that. But then if you have used things like morphine or hydromorphone, so this drug here, once you stop giving it, you may only see the effect after 6-8 hours, like that. So it's longer time. You don't have such a like precise control of it. But of course, if you look at the cost, fentanyl will be so much more expensive compared to morphine. So that's the trade-off. And then furthermore, if you want to use more fentanyl, you look at it, you have to administer in terms of a constant rate infusion. And the proper way to actually like precisely able to give this infusion rate properly is that you use a proper, what we call as a syringe pump. Whereas compared to morphine, like it's less precise, but then you give it as a usually it's a subcut or a IM injection, and it can last longer. So then you don't have you don't need a special gadget to actually like do that. That is the advantage of doing that. Okay, disadvantage, of course, less control of it, and of course slightly more side effects from the morphine. Okay, so I'll give you another one. You should actually like try to read up and like what is the side effect of morphine, because when you come to clinics, some of us we actually like be using this, so you need to know what is the side effect of morphine. Okay, every drugs like have the use, you should also know what could be the side effect and the shortcoming of it, so that when you use it, then you always have that consideration of like how is it you have that side effect, what should you do to minimize that risk. Okay, all right. Foreign body to me is more or less like about the same lah. Okay, I mean like the principles on it is the same with the GDV. Of course, GDV is actually like like more acute in that sense of like the moment it's dilated, it can compromise on your venous return and the cardiac output, and it will go into shock. With the enterotomy, no matter how distended, it may not actually like immediate cause, but that area, if it's actually like necrotized and if it perforated, you'll go into septicemia, and that is also will be very life-threatening as well. Okay. Same thing, need to consider about the acid-base imbalance. I have a question here about the antibiotics that you mentioned here. So obviously, it is not like, for example, you put here distal small intestine. This metazone or cephalosporin, is it actually like used in combination or use either one?
From the book that I read, it was actually either one, doctor. We can use cefazolin, cefmetazole, or cefoxitin. And then one more that I saw was that we can use first generation like cefazolin with metronidazole, but I'm not quite sure about the dosage for that one.
Oh, okay. Thank you. All right. So this area is actually like not really my area, so that's why I just like interested to find out. I think for you guys who are actually like doing this, especially when you are in the clinic handle case, the drugs that is actually like put in the textbook, especially in fact even in antibiotics, also will be different from what is being used in the practice. So perhaps you should continue to actually like read up more. How is it, like these drugs, if you don't have it, like if you don't use it, how is it compared with actually like other drugs that's available? I mean antibiotics that's available. Yeah. So maybe something for you to continue to think about lah on your prophylactic antibiotics. Okay, I highlight again here the red color on xylazine. So again, same. So the moment you are talking about, like condition related to GIT, usually cardiovascularly, like their fluid imbalance and all that, preclude use from using drugs such as xylazine. So try not to use it lah. Okay, that's to be on the careful side. Okay. The part on atropine, I don't have much, like you can or you, I mean, like, is it a must that you must include atropine in it? I don't really see that unless, like your rationale, I guess, is probably the same as previously one of you who asked, because you are handling the intestine. So you think that when you're handling intestine, there may be higher chance that you may, what do you call it, elicit the vagal reflex, and therefore that would be the justification that you should include atropine in the pre-medication. I can accept that if that is your justification. So, but other than that, is it always that it will happen and you can elicit vagal stimulation, as I said just now? And I didn't really notice lah, okay? I didn't really notice, okay? I guess that's it, all right? Then similarly in here, because again, this related to, like GI. So I'm asking you all to actually like just check again, is there any precaution or contraindication in the use of this in the case of intestinal tract surgery or concerns of perfusion or circulation to the injured intestine? Okay. Question. For prophylactic antibiotics, one reference mentioned that we need to redose after 2 hours and another mentioned every 60 to 90 minutes. Is it up to surgeon's preference, doctor? Is it up to surgeon's preference? If you ask me in the practice here, I would say that yeah lah, you have the surgeon's practice, but perhaps then I should refer you to, like when for some, if like what is the rationale that they come up with the recommendation that to this antibiotic to be redosed 2 hours or the other one every 60 to 90 minutes. What is the basis that this is actually like should be done, and using what kind of antibiotics? So, and then compare to, perhaps you all have start attending rounds, so to pay attention, and the way that's been practiced are probably different. They don't have the IV type of antibiotics, and they were using some long-acting drugs, and then and they probably are not practicing what is being written in here. It's a good question to actually like ask, like, is it up to the preference, surgeon preference? So at this point here, it looks like it is, because here don't have that certain protocol. But that's why I'm challenging that actually, like like if Fossum recommended something like this, it have to be based on some work that has been done to come up with such a recommendation. So, and then yeah, so I don't have an answer for that. So perhaps you can refer this to in this case here, this under GI, right? Dr. Ong is the one covering. Maybe you can post this question to Dr. Ong. Okay, that's number one. But other than that, I think you should actually like ask on the question, the rationale behind this recommendation by Fossum to redose every 2 hours. To me, it have to actually like do with you need to know the pharmacokinetics of the drugs, the pharmacokinetics, number one. Then second is actually like it have to do with actually like what is the if you talk about antibiotics, like go back to your pharmacology, you should be asking question as what is the target plasma concentration, or better still, you should be looking into tissue concentration that can be achieved of the antibiotics at your target tissue. And is the tissue concentration you achieve reach the minimum inhibitory concentration that can either is it inhibit or kill the target bacteria that you want at the target tissue. So that should be the rationale thinking on how you should be like targeting on the use of the antibiotics. Okay. Okay, so this one here, if I ask this question, then maybe after this, then or maybe can we decide here? You think this week is week 3, right? Would you all want to come back, and answer these questions? Can we give some deadline? Either you want to decide now or maybe decide later, that you give yourself like a certain deadline that we can agree that you will come back to this and not let this go off like that lah. So at least like there is some sort of like follow up from here, and you have do further reading to try to answer these questions, and then from there only we move on. So and then you can keep this for your future reference to read back, okay, to read up. Okay, we move on. Perineal hernia, 10. Okay, I purposely put here 10-year-old lah, okay, because usually we also see perineal hernia in geriatric animal, okay, and usually we'll tend to see it related to uncastrated male dog. We tend to actually like see this, okay. I kind of highlight here because I don't understand how perineal hernia can be related to air-filled stomach in the thoracic cavity. So maybe group 1 got this problem, or you refer somewhere that is actually like you see this problem as well, group 1?
Okay, hello, doctor. Actually, this one is if there is a traumatic injury, then maybe the dog is presented with diaphragmatic hernia also.
Oh, I see.
Yeah,
Okay.
yeah.
So you were referring to possible of hernia due to trauma lah. Okay,
Yes.
I see. All right. But if it's perineal hernia, you know what's perineal hernia, right? Where
Yes,
is there?
doctor.
It's the perineum, okay? It's the perineum, and then it's usually related to the animal has been having usually other problem and been always straining either during usually to defecate and so on, or during urination, and therefore causing some the problem about the tissue, and therefore having that hernia at the perineum. Okay. Further questions? Same group. Then I want to ask. I ask you why short term. So why give why do you aim for short term pain relief with fentanyl?
Hello, doctor.
Hi.
So, is it because the short term duration could be like only 45 minutes, and the surgery only took like an hour to be done? So, is it because of that we choose short terms?
Yeah, that's why I asked you back. Because if this is a perineal hernia, I think I mean, like I have a problem. You say you just want short-term pain relief. I would want actually, like, I think post-op pain relief is very important. It will be, I think the animal will be in pain post-operatively. So in fact, if we can for this animal, I would want to do an epidural for good post-op pain relief and not short-term pain relief lah. That's the way I see it lah. So unless this one again refer to your whatever diaphragmatic hernia, but even diaphragmatic hernia repair, post-op is also very important. Like if it's a diaphragmatic hernia after repair, the animal actually, like, it can be quite painful, and sometimes you can see if the animal don't have a good pain relief, they are reluctant to breathe, because every time they breathe they feel the pain and the tense on their diaphragm, and breathe very shallow, very very scared to breathe. So but if you have adequate pain relief, then they are a bit more relaxed and can breathe better. So adequate pain relief post-op is also very important, and that's why I don't understand why I can't see the rationale of using a short-term pain relief for this case. Unless again you say that actually, like, it's important to have very precise control of the the use of opioid, if that's the thing lah. But I don't see it, like, meaning actually, like, I kind of like in a way disagree that you should use with a short-term pain relief lah in such a case. Okay. What block? You put here blocks, question mark.
It's the epidural block actually.
Oh, epidural block. Okay.
Yes,
So
yes.
we need to
It's the
consider
opioid.
epidural block for post-op analgesia lah. Yeah.
Uh,
For
can we use for meaning during pre-op also,
yeah,
or the
if it's
epidural?
yeah, I agree. If let's say, you know, like we have this case, whenever possible is to try to do the block. And the block will be actually like do the block once the animal is induced. And then we do the block. And then that means before they even start the surgery, the block is already there. And it can confer intra-op as well as post-op analgesia. And that would be the most ideal, because intra-op analgesia itself will also reduce the requirement of the isoflurane or sevoflurane to use for maintenance. So definitely to try to do the block. Okay. And the block that to do is, I think for sure, if you do y'all know, do y'all have learned blocks, right? About have you been actually like talk about what is a cranial block and what is a caudal block? Cranial epidural block versus a caudal epidural block. Have you learned these terms? Yes, okay. So so in this case here, I think, is it when there was actually like, oh, is it a few weeks back? Somebody, when we were presenting cases, somebody was saying that actually like trying out a caudal block, and then they say that their block didn't work well to actually like block the perineal space because they were using a caudal block. So I can't comment on that. To me, theoretically, if you actually like learn up, you know, what you learn from, you know, when you're doing the block on the ruminant, right? Where you're doing at the sacrum coccygeal space, or actually like between coccygeal 1 and coccygeal 2, the volume you use actually like supposed to be able to cover the perineum. So should probably actually like help, you know, like block off that perineal space. But maybe in terms of actually like perineal hernia repair, if the area that need to be covered is more than you know, like what is being covered by the sensory innervation of just from the caudal nerve that exit from the coccygeal 1 and 2, if you need further, then maybe have to go higher up with more volume, covering a slightly anterior portion of the caudal equina. Okay, and then if you want to be a bit more to be for sure to definitely cover everything, then maybe actually like in small animal, if the animal is under GA, also quite easy to do the lumbosacral space. So with that, usually you're doing like more like a cranial block lah, and that can cover more space. Usually that will also cover the hind limb. Okay, the hind limb, that is a femoral nerve as well, is being covered lah. Okay. All right. This one here, can the group actually like check on your aspromazine dose, because it is ridiculously high? So if not mistaken, it should be 0.05 to maybe 0.1. Cannot be 1.1. It's too high with the ACE. And I think I was taken somewhere, somebody write a ridiculously low aspromazine. So those are important to actually like check on your dose. Okay, so I just want to emphasize here, although actually like it says, oh yeah, that's just dose. Okay, but if let's say in actual practice and you have not paid attention to even this you know, like what is your dose in terms of like where you place the decimal point, it make a big difference. Okay, it really make a big difference between 10 times or not, because when you're talking about anesthetic drugs, even actually like a 1-fold make a difference. What's more, if you're talking about a 10-fold. So, and that is actually like, it's a no mistake. Okay, have to emphasize on this. Mistake such as this must not happen. And we have actually like seen it in some of your, actually like, it's just like 1 or 2 case, but because it happened and actually like it's bad for the case. So we do not want anybody to make or repeat any of this mistake of actually like overdosing the animal with any of this anesthetic, and neither with actually like the non-steroidal meloxicam. Meloxicam has also been one that has been, people do not know how to, we don't understand why you know, you cannot read when we say that take 0.3 mils, and instead of taking a 0.3 mils, you have take up 3 mils and actually like injected to the poor cats. So, and of course, the poor cat will end up with, 10 times the dose that is supposed to give and end up with toxicity. So, and that is actually is a no mistake. All right. So always check when you're always talking about anesthetic, you have to be extra careful that you don't make this very silly, but it's a very serious mistake. Okay. Please don't do that. So decimal point, very important to take very careful note of it. Okay. All right. Okay. The other thing that I add on in here, the rest you have written, because if I purposely put here as a 10-year-old, so I expect that in your workup that you should mention things like you should check out whether like how is the heart, how's the respiratory system, were there any disease in this, okay, other than your liver and the kidney, okay. But in majority of like all cases, cardiorespiratory system is the most important system that you must check before you you let the animal go for surgery under anesthesia, because any disease of this system can actually like compromise on the patient safety like under GA. Okay. Diluted in saline. Do you have your answer already, or what is the dilution?
Doctor, we use 1-to-1 ratio to dilute.
1-to-1 ratio bupivacaine to the saline. Okay.
Yeah.
All right. That's acceptable. Thank you.
All right. Thank you, doctor.
This one here you all read lah. Okay, but I have questions. So what is PST? What is PTE? Can group any groups apa? Group 12, can you explain a bit? Group 12. Okay lah. If you're not ready, then maybe later you explain to the class, and but ideally, if let's say you have, because there's a lot of like big words that's actually written in here. Okay, let me just actually like again, so I notice here things like again this one here to I think this dose is just too low, so can the group please check back on here? Okay, 0.1 to 0.2, this probably refer to midazolam and not propofol. So just we check propofol dose probably is not that. But if that's what it is, then please respond and say that that's what it is. Give the reference. I kind of like highlight this pink color on IV morphine. So this is just another general knowledge that you should know. Morphine is actually like it again is not to say you cannot give morphine IV, but to take note that actually like morphine when it's given as a high dose and as a bolus IV has been shown to cause some release of mast cell, and people have I think this is more to human, that a slight drop in blood pressure. So just to be aware, the textbook have said something like this. So, but again, in practice, do I notice a problem if I give morphine IV? Because of the knowledge that I have, so that's why when I give morphine, often I don't give it as a bolus. I'll just give it slowly over 30 seconds or so on. And as I give, I do actually like take note and see whether there is a drop in the pressure. So most of the time, I have no problem giving it IV lah. But then because the textbook have said something like this, something that you want to take note. There is also another drug known called as a pethidine. So pethidine is worse than morphine in terms of when you give IV, that it can cause release of the mast cell and sorry, is it mast cell? Yeah, release of the histamine from the mast cell, and therefore drop in blood pressure. This one here again, personally, I don't have that experience because I've read about it, and then I've actually make sure I've never used pethidine IV. I've always used IM. I have our teacher, Dr. Nazira Chen. So for her, she said she have used IV and she really have seen adverse effect after giving that pethidine IV. And since people have said that, so I never tried that. So if you don't believe, I guess you can try it out and actually see just to, but then you have to be careful. You have to take note that I have emphasized to the whole class that it has been reported, and therefore please take that precaution when you're dealing with pethidine or morphine IV. Okay. All right. The next case about ear ablation. All right. So, what is it, Iqbal? Corrected dose for ACE is 0.1 to 0.2. Dog is 0.05 to 1.5. Okay. So the dog dose at 1.5 milligram, that's quite a high dose of ACE promazine. Okay, I have never used actually such a high dose of ACE promazine. I'm not sure how long it will actually last for the dog. So just take note of that. So my experience so far is actually go up to perhaps it's just 0.2 in a cat. I am not experienced with actually using more than 1 milligram per kilogram ACE. So be careful of the dose. All right. Okay, what I want to say about the Teka and Bule. So this one here, more importantly, is to take note of the pain. All right, pain relief is very important. It's a very painful procedure. So we find that actually like these animals is actually like having a good opioids in the pre-medication, and in fact for the recovery itself, usually they have a good already another top-up dose of opioid for it to recover. If not, this animal wake up really painful and they'll be really screaming like with pain when they recover. So I find it a very challenge to maintain, like to have the animal recover well from this. Okay. The other thing on here, the rest is actually you can read lah, huh? Okay. FURD, okay, in the eye. So for this here, okay, I think I'm asking, okay, the part because of obviously because I put here a kitten, so like I did put in a age group. So please actually like revise about actually like kitten, when kitten or even I actually like pediatrics in terms of pediatrics, when is it that the liver and the kidney actually matured, so that actually like the drugs when you are using it to consider like whether they will have problem in terms of excreting the drugs. Okay, but the rest that in terms of challenge that you face when you are dealing with actually kittens is all has been highlighted here. They are small. It's very hard to get your IV access. It's very hard to get the airway access. So it's can be a challenge if you have a ruptured eyeball and you actually like need to do eye enucleation. So luckily here we have actually like our technician have learned like to really try to get an IV access. So the moment we can able to get an IV access, so it will not be a big problem, because then we can go with drugs that give IV like propofol, and that would be a better control. The other challenge is actually like to have a endotracheal tube that is small enough that we can intubate this kitten, because if not it's going to be like a challenge. There's no way that you can maintain the animal on gas using mask if you don't have the endotracheal tube that you can intubate the trachea. So you want to maintain the animal on gas anesthesia using mask, there's just no way, because it will be interfering with actually the surgeon access to the eye where you want to actually like remove the eyeball. So either it's you don't have an airway and you have to maintain using injectable, or you have to work out how you can get the airway. So the smallest the smallest endotracheal tube that's available in market is only the 2.5. Sorry, I think maybe there's also a 2.0 endotracheal tube. So if there's none, then perhaps then you would probably have to like have some innovation, look out for whatever, maybe catheter, and try to modify the catheter in such a way that you can like get it small enough that you can intubate. So that would be the best way lah. Because if you can maintain with gas, as I said, gas anesthesia is the easiest to maintain the animal. Then once you off the anesthetic, the animal can wake up quickly. All right, so that would be the challenge. But other than that, things like bradycardia, all those things that's written by your friends is all applicable and make the things challenging. So typically in general for kitten, puppy, usually in the pre-med, oh, you all didn't write here. Since you say that they're actually like prone to bradycardia, so usually in the pre-med, in the protocol, you should include a anticholinergic. So you should put in an atropine in the pre-med. All right, so that's number one for because it's young animal. And then second justification for pre-med with atropine is that when you're dealing with actually